Dr. Mohammed, the floor is yours. Dr. Mohammed, the floor is yours.
Okay, thank you. Assalamu alaikum. Thanks for the invitation, and I would like to thank the organizing committee and the scientific committee for this great meeting. So as you can see, the title of my talk and the focus of my talk is about the curative IR treatments. And I said towards curative IR treatments because we know for a fact that we don't provide what we call curative apart from ablative therapies. So I have no disclosures. So just a quick reminder of what we have in IR and our artillery of treatments. We have alcohol ablation as one of the options. We have thermal ablation, specifically for smaller lesions than 5 centimeter, bland embolization, chemoembolization, and radioembolization. And everything we provide is, in fact, we intend to be curative in the context of our treatments, such as combination with systemic therapy, with resection, with transplantation, whether we provide downstaging, bridging. So if we look at the BCLC staging system, the modified BCLC staging system published in 2018, when we talk about curative treatment, we're aiming at very early stage 0 or early stage HCC, which is A, and everything is either resection, ablation, or transplantation. So this staging system does not specifically mention transarterial chemoembolization or radioembolization as part of the treatment options can be offered for these patients. And even if, when we talk about ablation or resection or transplantation, we're talking about 60 to 80% 5-year survival in these patients, specifically stage 0 or stage A. And we know for a fact that radiofrequency ablation can provide comparable results to surgical resections select patients. And and for both resection and ablation, we all know that there is a chance at least as high, maybe at least 75% of these patients may come back later with either residual, recurrent, or new lesions somewhere else if the patient is not transplanted. So we're aiming at curative intakes, not curative intent. Everything we do, we're aiming towards transplantation if we can. But for fact, we know in practice is not happening all the time, and it's not possible in many instances. So the ISMO guidelines, which was published lately in March 2021, it includes more of IR treatments as options for the management of HCC. It does include TACE as one of the options as for early stage, very early stage. And also it offers the radioembolization as one of the options as alternative in specific select set of patients. And also we have to keep in mind all the time that there's something that we call an IR stage migration concept. So we can treat one patient who has very early stage with more advanced type of treatment, such as radioembolization. So instead of ablation, we can treat with radiation segmentectomy or TACE because it is more suitable for the specific patient. We were talking about personalized medicine now in IR and oncology. So we can downstage or upstage the treatment based on the specific patient. So we don't have to follow the specific guidelines for every single patient. We can personalize the treatment according to these patients. So to understand the challenges that we face in IR when we select these patients, specifically for thermal ablation aiming at curative intent, we have to keep in mind the very important concept, which is the achieving what we call A0, which is equivalent to R0 in resection. So we have to have a safety margin of at least 0.5 centimeter from each circumferential to all dimensions of the tumor in order to achieve good ablation, make sure that the tumor will not come back, will not have any residual. And this is not possible all the time for thermal ablation because of patient-specific issues, whether the lesion is not visualized, the patient body habitus is quite big, not possible to treat with ablation, or because of lesion-specific characteristics, such as the heat sink effect, which applies in radiofrequency ablation. We have the alternative of microwave. Central lesions close to biliary radicals may cause biliary damage, so we prefer not to treat with ablation therapy. That's why we shift the patient from one treatment to the other treatment. subcapsular lesions, possibility of insufficient margins, potential rupture, subdiaphragmatic location, which can be quite difficult to access, and sometimes we have to go transpleural, which adds to the risk of complications, pericardial location, proximity to GI tract, and all of these may play into the lower curative rate from thermal ablation. This is why we sometimes switch from ablative therapy to the transarterial therapies in order to achieve better outcome and bridge the patient or downstage the patient to a resection or transplantation. So this is one example of RFA, 3 centimeter lesion targeted by RFA, complete response on follow-up exam. So this is one of the best candidates for ablation therapy. This is does not happen all the time in practice. We know for a fact this is not the case. This is another patient who had solitary 3.3 HCC lesion in segment 2, very close to the pericardium. Here you can see the left lobe. It's sitting immediately next to the pericardium. Yes, we can do it, but we had to take the risk sometimes. And the patient was planned for transplantation. So we in fact did ablation with microwave, and you see the needle going into the lesion, very close to the edge of the liver. This is follow-up scan, complete ablation cavity, complete necrosis, and later the patient was transplanted, and this is a 1-year follow-up CT scan after the transplantation. So the aim, the goal is to achieve curative context, not curative intent. We know the ultimate goal is to have transplantation for most of these patients. TACE, also another option that may be offered for very early stage curative intent or early stage HCC. And we know from the guidelines that it's offered technically in intermediate stage BCLC B, not A or 0. And we have always the concern of portal vein invasion. We consider the multiplicity of the lesions, whether it will achieve the curative intent or not. Vascularity of the lesion itself is a very important factor for us in order to make sure that the lesion will be completely saturated and ablated by the chemotherapy. Tumor supply, it can be very challenging sometimes, especially if the patient had many previous treatments, whether systemic with the anti-angiogenesis treatments or the local regional treatments before. It may completely disrupt the way the tumor is vascularized. It may make it very difficult and challenging to target this lesion and achieve curative treatment. Extrahepatic supply is another challenging thing that may end up with residual or recurrent because of the accessory supply to the tumor that may cause recurrence or residual, and prior biliary intervention, which may add also to the risk of complications. Now, with the new techniques, with the advances of TACE, that's why we're seeing more and more TACE or transarterial therapies being done because of the advances in techniques. Now we have the drug-eluting beads that allow to achieve better treatments, hopefully better treatments with less complications. The survival outcomes and the response is probably the same as previous conventional TACE, but it seems that the safety profile is better with drug-eluting beads. Super selective techniques. We have now microcatheters, other techniques that allows us to go as close as to the tumor itself sometimes and inject immediately into the tumor with the chemotherapy and the drug-eluting beads. This allows to better control the tumor, prevent additional supply to the tumor itself. Cone beam CT, now we have it in most of the angiography suites that allows us to localize the tumor to a better degree and make sure that we are definitely supplying the entire lesion, saturating the entire lesion in order to make sure that they will not have any residual or recurrence, aiming for curative intent. This is an example of TACE, 10 centimeter lesion, treated with the DEB-TACE, 150 milligram of doxorubicin, CR on follow-up examination. So we're aiming at curative intent for these patients. It is quite important to make sure that we cover the entire vascular supply to this lesion from all vessels. Another advance in the treatment options that we have TACE and ablation. So we can ablate saturate the lesion with the TACE, and if we have any missing part of it, that can be ablated, as in this case, we missed part of the lesion, which was targeted later on by microwave in order to achieve complete necrosis of the tumor. DEB-TACE in addition to ablation, can be offered not necessarily for the same lesion, can be in sequence. Sometimes we treat same patient, one lesion with TACE, one lesion with microwave, other lesion with the radioembolization based on the suitability for the treatment. This is another example of patient with child A, performance status 0, 3 centimeter lesion in segment 5, initially treated with microwave ablation. Later on follow-up after 1 year, he had another lesion in the dome, which was not suitable for microwave. Ultimately treated with the TACE, then follow-up, finally ended up with transplantation. So we are bridging the patient towards the curative intent with transplantation. So we are working in a curative context. Another example of multiple lesions, 2 of them definitively HCC. This is the one which was targeted initially by microwave, and the second one was very high in the dome, which is not very easily accessible for microwave. It was targeted by TACE, and the patient ultimately had a complete response on the follow-up scan, and ultimately he ended up with the transplantation. So again, we're aiming for curative context. So now the question is whether to offer TACE versus TARE, and we know this from the premier trial by Northwestern Group from Riyadh Salim. This is a trial, phase 2, BCLC A and B, randomized 24 to 21 patients. So the findings of this trial indicate that radioembolization, in fact, prolongs time to progression from 6.8 with the conventional TACE month to more than 26 months with radioembolization. And in fact, this prolongation of time to progression may, in fact, cause more patients to go into transplantation because you have more window, longer window, and you have also the test of time. So if the patient has not progressed over the next 20 months, 30 months, then you have more window to transplantation, and you know the prognosis will be better. This is a meta-analysis of radioembolization versus chemoembolization, including all 3 trials, including the premier trial. And again, also, although it does not say that survival is overall survival is better, but we can see that there's a higher proportion of patients who ended up in transplantation with radioembolization. This is the legacy study, multi-center introspective analysis, single arm, HCC lesions smaller than 8 centimeter, child A equals 0 to 1. The rate of transplantation was 21 at the end after the radioembolization, or ended up with the resection. So we're getting closer to curative intent, bridging the patients toward the either resection or transplantation. This is an example from our institution. Patient had a very large lesion, initially treated with radioembolization in 2015, then another dose at the end of 2015. Very good response, ended up with resection, and here's his scan like 2 years after his initial presentation. So we're aiming at curative intent in addition to multiple other modalities. Radiation segmentectomy is a very important thing that we are practicing nowadays. It allows us to deliver very high radiation doses in specific locations, whether the segment itself or the tumor itself. It allows to minimize the collateral damage to adjacent parenchyma. And technically, this is technical aspect. We have to deliver at least 190 gray to the segment with the therapy, or at least 120 gray with the rest in cervix. So this is a study by the Northwestern Group, again, 70 patients, solitary HCC, treated with the radiation segmentectomy, and 72% of the patients, they had no target lesion progression at 5 years. And median overall survival, we're talking about 6.7 years now. So it's a curative treatment. And if you compare it to other treatments, including surgical resection and ablation, radiation segmentectomy does very well compared to other treatment methods. This is an example from our institution, 85-year-old patient, a child A, performance status 0, solitary HCC lesion in segment 6 and 7, treated with radiation segmentectomy, sees significant concentration of radioactivity in the lesion itself. Even the adjacent parenchyma is not even contaminated with the radioembolization, and this is almost 1 year follow-up, complete necrosis of the lesion cavity. This is again radiation segmentectomy working in context of other treatments. This is a patient maybe Dr. Kannan knows him. Patient had previous radiation segmentectomy to segment 4 in February 2020. He had complete necrosis on imaging, ended up with a section, resected the segment. On pathology, they found 2.5 residual lesion with 50 to 60% necrosis. And we know for a fact these patients end up with progression later on. He progressed with several additional lesions in the left lobe. We treated him with radioembolization in order to prepare him for the immunotherapy treatment that may add to his survival. So now we're talking about combining radioembolization and systemic therapy and immunotherapy as well. We have the ceramic trial, which is the CERT plus sorafenib, which suggests that these patients may have benefit from adding radioembolization to systemic therapy. Specific group of young. The NASR HCC study, which has not been published yet, it's a registry of 40 patients, prospective study. It shows that there's good favorable safety profile of adding nivolumab to radioembolization patients in order to increase the survival. Overall response was 40%, and the complete response was 12.5%. Partial response was 27.5%. So now we're talking about treating more advanced stages with curative intent or curative context treatments. So this is an example from our institution. 41-year-old patient, ECOG 0, child A, very large tumor with limited segmental vascular invasion, was initially treated with radioembolization and aimed to resect him. Unfortunately, he progressed a little bit and had metastasis down the road. Started him on 2 lines of chemotherapy. The second line was nivolumab, 12 cycles. At 12 months, he received additional radioembolization dose with very ablative dose, 300 gray. And later on, almost like 7 months after the second radioembolization and continuing of the chemotherapy, he ended up with the CR. And his lung metastasis nearly completely resolved. So we're aiming at curative intent. Patient, very young. We're talking about like 2 years survival so far for these patients. Another example, patient treated with the first line chemotherapy, atezolizumab, for 1 year. They ended up with the slight progression in the left and the right lobes, and treated with radioembolization, lobar for right and left. And his final scan in 1 month ago showed very good response. Hopefully, we can extend the survival of these patients. Even at the very advanced stages, we can work on improving their survival longer and longer, maybe aim to curative intent. So basically, curative IR treatments play an important role in the early stages of HCC. Local regional therapies may help as a new adjuvant to resection or transplantation in select patients. And combining local regional and systemic therapies may expand the potential options and treatments for more advanced stages. And hopefully, maybe down the road, we can see more advances in immunotherapy and combining these treatments, and definitely more research is needed. Thank you so much.
Thank you very much, Dr. Arun, for this interesting talk. I would like to remind all attendees, as well as people who are attending in the virtual, to send their question to the question and answer box, or even through the chat, and we will collect them, me and my chair, Dr. Fuad. Now it is my pleasure to present and